Good morning and welcome to another edition of To The Point. It is Wednesday, April 22nd, 2020. We apologize for the late start to this morning's program, just ensuring that technology can cooperate with us as we get this morning's program underway. I have joining me virtually is Acting Chief Medical Officer in the Ministry of Health, Dr. Francis Martin. And later in the program, we are expecting to be joined by Epidemiologist Dr.Shawn Charles. But we're going to start the program with Dr. Martin in the meantime. Good morning, Doc.
Hi, good morning. How are you?
I'm good. I haven't seen you in a while.
Oh, really?
Yes, it's been a while, co-host. I've missed you, co-host.
I've been to work every day since.
I know, working hard on ensuring we stay COVID-19 or we contain it as much as possible.
Yeah.
So we're going to get right into it, Doc. First thing on the agenda, an update on what could possibly be patient 15 or a confirmed positive patient 15. The last we heard was that the officials wanted to do 2 more PCR tests before revealing the results. Any updates as it relates to that?
Right. Well, the updates is a very simple one. Probably the update is what you already know. We have admitted him. He's in stable condition at the moment. As you can imagine, that case is a very pivotal case in our COVID response. It would really top all the responses that we've had thus far. And so confirming the case and the status of the case is quite important for us. We have indeed started the process of confirmation. But as you can imagine, a case like that, we have our reference labs that we would send the case to make sure that the result we get is indeed the case that we get. So I'm looking forward to that pretty soon. I think by the end of probably tomorrow, our reference lab would be able to tell us the true indication of the case. But that being said, as medical doctors, what we do, we function on differential diagnosis. If something looks like a dog, walks like a dog, it's probably a dog. So we are functioning on the premise that it is a lung infection, a possible COVID case, and erring on the side of caution, we are treating it as such until the confirmation comes.
It seems a bit
Well, as a matter of fact, referring cases to reference lab is a normal process for lab functions around the region. As a matter of fact, labs are supposed to do this from time to time just to ensure that they're on the same wavelength. So that's a normal lab function. But, in this instance, because it is such an important case, we figured we should do that as well.
How, should I say optimistic, but what are your expectations? Like you said, if it walks like a duck and quacks like a duck, it's a duck. But is it a case where we're not sure or we're positive, we just want to see the written results?
As a medical doctor, it's best that you see the written results. You're supposed to act like if someone has meningitis, for example, you don't wait until the results come back. It looks like that, you treat it and just wait for your results. And that's how we function as physicians.
And that should be by by tomorrow, please, Lord, hopefully?
I would say certainly. Well, I don't want to use the word certainly. You have to be careful not to. But I'm just as anxious as you are. So let's hope by day end or certainly tomorrow morning we should hear something.
And with this case, which would possibly be our first case of community spread, how does that change the direction of the medical experts in terms of the contact tracing and ensuring that we do what we need to do to confirm, where he got it and so on and so forth?
Well, the contact tracing has begun. And it's only after you do your proper investigation can you actually see that this is a community transmission case or a community spread case. We don't have enough information yet to confirm that it is a community transmitted case. The epidemiologist and myself has started the investigation. The investigation is continuing this morning. But as you can imagine, a case like that requires real detailed investigation to really drill down into where the possible infection could have originated. And this is what we're doing at the moment.
Is it worrying, knowing, this one, should I just say pop up out of nowhere? But, yeah, go on.
I would probably describe myself in two respects. One, in the sense that if it is indeed a case, then it really cuts out our work for us and what we thought was difficult work that we've been doing up until this point. it looks like it's going to become even more difficult work going forward in the immediate future. And that's really how I look at it. So I'm just actually preparing myself for more difficult work, more hard work in the foreseeable future.
One of the comments that I've heard from members of the public was that it was just days prior that we were basically praising ourselves that we have, 7 recovered patients and we're well on our way to being COVID-19 free, and up comes possible patient number 15. Do you think that has anything to do with the way that we have been operating during our 24-hour curfew, easing of the regulations and so on?
Well, you have to look and contextualize this in regards to what's happening in our sub-region and worldwide. What has happened or what is unfolding in Grenada is not unusual for this particular coronavirus. That has been the nature of this virus worldwide. So what was happening here is not unusual. I don't even think that it has to do with lifting of restrictions or the way we've been functioning, because, the lifting of restrictions didn't suddenly show up the case. The lifting of restrictions came almost the same time as the case in itself. I think this goes back to Grenadians themselves, or behavior, and how we personally treated with this matter of the restrictions. The majority of Grenadians have followed the restrictions very well. But as we've always said, there is going to be the 1 or 2 persons who will not follow the directions as we, indicate that they should. And those 1 or 2 persons we always said that those 1 or 2 persons have had the potential of causing or progress to be hampered. So what I am seeing is a normal progress of how the disease happens everywhere else. It's just that it, like I said before, it just really underscores that we still need to keep our guards up, and every Grenadian need to do their part to help us stem this tide.
Is it possible that the COVID-19 test can pick up any other respiratory illnesses besides COVID-19?
Well, in this particular instance, that's why I said earlier, doctors function on a premise of differential diagnosis. Differential diagnosis means if someone has a set of symptoms, you identify the types of infections that could cause this infection. So influenza can cause that. H1N1 can cause that. Chemical pneumonitis can cause that. And of course, COVID can cause it as well. So these are all the things that the doctors will be looking at to identify if it is not COVID-19, what else can it be? And then if it's COVID-19, of course, then it is COVID-19. The first test done on the patient, are you able to tell us what was the result of the first one before we did the other 2? Well, having not seen it myself, but trusting my clinicians, the test was negative and thereafter became positive.
Okay. So 2 tests were done, 1 came negative, 1 came positive. So to kind of break that tie, you wanted to do the other 2 PCR tests.
It makes a lot of sense, and that's what we've been preaching all along.
Okay, I just wanted to because that was my thought process, so I wanted to verify from the experts exactly what was taking place. Okay, let's maybe move on for the time being from possible patient 15 to our previous 14 patients. We have 7 recovery. How are they doing? And the 6 that are still active, updates on them.
I am glad that so far their performance has been consistent with what we knew all along, that many of them are going to recover, and they're going to recover doing pretty good. So I'm happy to report that they continue to do very well. We haven't had no significant reports from them. Our concern for them is the psychological support. How are they able to function again? And let's not refuse to look at the psychological impact it can have on them, and how society we're going to accept them. These are people who've gone through an infection and will become well, and for all intents and purposes will have the ability to rejoin society with no problems. I just hope that we as a people are going to not continue the stigma and discrimination against people of that nature. So far they're good. We hope they continue to be as good as long as they can, and see how it goes from there.
The 3 patients that were in ICU, they're still in ICU or are they out?
We have to, sometimes the things ICU and isolation unit is used interchangeably, but we have to be careful. As a doctor, I have to say the right thing, which is an ICU is an intensive care unit. None of the patients are in ICU. ICU is an intensive care unit. That's where people go when they're really, really sick and they need mechanical ventilation and all sorts of intensive care.
Okay. So they're in isolation.
Okay. They are in the isolation unit. And they're there doing very well. Thankfully, none of them are on mechanical ventilation at the moment. They're stable on oxygen and receiving the treatment that our medical team is providing for them.
So the 3 of them are still in isolation, just to confirm? All 3 or just 1 or 2?
I think I have to confirm with my medical director, but I think it is 2 at the moment. I think one was discharged and the other one, and then of course the last one that came has joined that person.
Okay, all right. The rapid tests, we've also been doing some rapid testing. When you addressed the news conference earlier this week, you spoke of just about 80 something or so that have been done. Have we done any more? And how trusted are the results from these rapid tests? I recall seeing an article from the WHO cautioning about relying on those tests and the results that they may bring or they may show.
Right.
Your thoughts?
Since the onset of coronavirus, rapid testing has been an issue as it relates to the efficacy of them and the accuracy of them. And with every epidemic, companies try to make cash in, if you want to put it that way. So we know that the issue of rapid tests is always going to be something of great concern to us. The rapid testing is an antibody testing. That means it relies on your body's ability to produce antibodies for a particular disease. And so one have to take a lot of the history of that patient into consideration before they chooses to use a rapid test. And it is because of those different things why rapid tests are so, we have to be so cautious about them. Granted, no test is 100%, and we all have to accept this. But the concerns of the world with rapid tests is credible, and it is something we need to think about. However, the world recognized that there is a place for rapid tests. There are people who would require, or people who meet the criteria for using of rapid tests. And so this is why the World Health Organization has asked that 2 major countries, United States and in England, for example, that they try out a specific brand of rapid tests in sort of a research to see how accurate they are and if it is accurate enough to be able to be used on populations. So while we recognize that there are risks associated with them, the World Health Organization still would like to have the best fit for the circumstances, if you want to put it that way. And so we are going to constantly wait on them for us to be able to, certainly, identify beyond any shadows of a doubt that a rapid test is available. So although rapid tests are available in our region, we are using it very cautiously until the WHO is able to tell us with all certainty that X, Y, or Z is possible to be used.
Does the concern from the WHO have anything to do with the origin of these rapid tests? Because go on.
I'm not aware that they have anything to do with the origin, but I think it may have to do with the performance of the test itself.
Okay. And our rapid test came from where?
I am not sure exactly where the test came from. I think that was addressed by some of the by our previous, in terms of where the gifts came from. But in terms,
there could be people walking around who are asymptomatic and passing on the virus. How big of a concern is that for the ministry?
Oh man, this is a big concern, not just for the ministry, but it was a big concern for us long before this particular era happening. The concerns about asymptomatic carriers, healthy carriers, if you want to put this way, and then the third category is airborne or aerosolization of the droplets. Those are 3 big issues that the scientists are working on, desperately to find if there is, there is credible evidence that is. I mean, I'll be honest with you, the more the science has developed, it's kind of looking more and more that this is actually possible. So we are very, very concerned about that, and hence the reason we have shifted our case definition over time to now include people who have no symptoms but have credible evidence that they may have been exposed, or they have whatever it is that makes you feel that there is a possibility. We are actually willing to test these people as well, to help, exonerate or disqualify whether or not people can be asymptomatic carriers, and you can actually identify someone who is asymptomatic and positive. So that is a big worry for us, because it means then that it calls for more resources, it calls for more time, it calls for more healthcare providers to go out there to provide the care. And of course, it opens up the window for us to actually have a lot more patients who are positive, and now we have to deal with more patients who are positive.
Going forward, how are we going to continue the containment of this virus? With the concern of asymptomatic carriers, with the concern of possibility of community spread, what's the next step in containment?
The next step in containment, to my mind, I have a little mantra, and the mantra is test, track, treat. The 3 T's. You have to test, track whoever is there, and treat. And that's how we're going to contain this. The more tests you can do, is the more tracking you can track. And tracking here means contact tracing, means whoever you were in contact with, or whatever it is. And treating here means those who are positive, quarantine them or isolate them. Those who are sick, treat them. And those who are negative, keep them away from people. And of course, those who are positive but well, keep them away. And that goes right back to what we've been saying from the beginning. Our citizens need to understand they must stay home. They must avoid congregation. I have had countless telephone calls of people commenting and reporting on others who deliberately disobeying the rule for, one person in a vehicle, or if there are 2 persons in a vehicle, one in the front, one in the back, wearing a face mask and so on. It really boils down to each individual again, and their ability to follow the rules that we've been telling them. And so I recognize the work that has to be done, but knowing that I've gotten all of those phone calls, to be honest, it makes me feel a little uneasy.
I could understand that. And speaking of tests, I remember that was one of the things that the health officials wanted to do in terms of stepping up the number of tests that we will carry out now that we can do our own local testing. How has that effort been going? Can you give us a figure as to how many tests have been carried out with both the PCR and rapid testing?
Yeah, I mean, I'm hoping that when we take a break, Dr. Charles could join us with some more details. But I am happy to say that we have done well. There's still a lot more to be done. I think I was checking out last night a slight guesstimation on where we are, because tests were continuing all yesterday and all this morning, and it's a few hundred rapid tests, and over 100 and something PCRs. So up to this point, I am happy that we've gone this level of testing and that we're continuing to. But now, as you do realize, we now need to step that up even further. Do we have the capacity to do so? Yes. Do we have the manpower? We probably need some more help, and hence the reason we're going to mobilize more for our health staff to come together and accept volunteers as well. Our private doctors are calling us, asking us to assist them in whatever way they can. And so I think we are now seeing a situation where a lot of our health providers are now all hands on deck and willing to go forward to help us with this mammoth task ahead of us.
And before we go to the break, in the earlies, there was an issue with the patients who have been confirmed positive not really adhering to the requirement of staying at home, quarantining at home, self-quarantining. Do we have cooperation now? Has that improved?
The self-quarantining has improved up to the point where we were happy we were able to get out of that scenario. Until now, this present circumstance is with us. So now we have to do a new evaluation to see our current contacts, how well are they doing with self-quarantining, And I'm pretty sure we'll have a general idea of how that's going as we've started our contact tracing yesterday. We're continuing today. So, by the end of the day, I'll probably get a better report from our healthcare field workers, how well people are quarantining. But I really do hope that those who are listening to this program who might have been already contacted by your private public health professional, if you have already been contacted by them and you know you are possibly at risk because you know your association, take the responsibility and self-quarantine until we can get to you. The call and the cry continues from us to you to help us in this matter.
Let's take a quick break, and during the break, hopefully Dr. Charles will be able to join us. We are speaking with Dr. Martin, an update on COVID-19. Stick and stay. This is To The Point on Classic, GBN and Hot. We'll be right back.
The best way to protect yourself from 2019 novel coronavirus is to avoid being exposed to the virus. Additionally, there are preventative actions that you can take to protect yourself and your family from the spread of respiratory viruses that can make you sick. These include stay home if you're sick, cover your cough, and wash your hands.
Feel good facts.
Help prevent cold and flu by washing your hands with soap and water for at least 20 seconds. That's the time it takes to remove most germs. No soap and water? No worries when you've got alcohol-based hand sanitizer.
We believe this new virus spreads mostly from person to person through respiratory droplets produced when someone who is sick coughs or sneezes. This is similar to how flu and other respiratory illnesses spread. These droplets can land in the mouth or nose of people nearby, or possibly be inhaled into the lungs. Most person-to-person spread happens when people are in close contact. It's also possible that this virus can spread when someone touches a contaminated surface and then touches the mouth, nose, or eyes.
Welcome back to The Point. We are talking COVID-19. We have Dr. Francis Martin, Acting Chief Medical Officer in the Ministry of Health, and we are being joined by epidemiologist Dr. Shawn Charles, who is finishing setup.
Yeah, I think his audio is trying to connect. It's possible that he may not be in his office and he might be in the field conducting contact tracing or so. He's probably trying to use his phone or so. Okay. So if it does not connect to us, it's probably because he's having that kind of technical difficulty, probably being out in the field, because I tried calling him in his office and didn't get through to him.
Okay, no problem. Understood. We know it's not normal times and it's busy time, so understood. At this point,
so if we cannot connect, don't worry too much. We can.
No problem. No problem at all. At this point, let's open the phone lines, 435-2041. You can call us on the landline. You can also WhatsApp in your message, written messages, questions, queries, concerns. On the WhatsApp, it's also 435-2041. You can send your questions on the GBN Television Facebook page or the Grenada Broadcasting Network's YouTube channel as well. If we can please keep our questions on the telephones to 1 minute or less so we can facilitate as many folks as possible, that would be appreciated. So let's take our very first phone call. Good
morning, citizen.
Good morning.
And greetings to your guest, Dr. Martin.
Morning.
Dr. Martin, of course, a medical doctor. I speak as a mechanic. In my job, equally as Dr. Martin, there's a term called specs and stats, abbreviated for specifications and statistics. And this, of course, what we use. I'm hearing a noise here. I hope it's not on my end.
Yes, go on. I'll work it out. Go ahead.
What we use to make precise decisions. Data, specific data. Now, the question was asked of the doctor. To give us an idea of you use the word amount, I choose to say the number of people treated so far. And he referred to, his answer was that quite a lot. And so I am not satisfied with that. We need percentage of people relative to the population. A proper ratio, doctor, is what we want. Details. So I hope, he did also refer to Dr. What the other one's name again? Charles, is it? Yes. So I hope that when he comes in, he comes with the information. We need numbers, percentage. Some of us see things in different ways. But at the same time, I also want to commend the doctor on his work so far, and I hope that he's keeping safe. And also my greetings and congratulations and felicitations go out to all the brothers and sisters out there trying to save the lives of the Grenadian people. Thank you very much, and have a nice day, will you?
Thank you, Citizen Rollo. Doc?
Yes, thank you. Did you ask me specifically how many people treated or how many people were admitted to the isolation unit?
I asked you about isolation. I asked you how many tests we've done. Maybe that's the one he's referring to.
Tests. Oh, okay, right.
Or even treated. Do you have any of the treated as well? How many folks have been treated?
Right, because the treated ones would be the ones that were admitted to hospital for treatment purposes. And so far, we have 4 persons that have been admitted over the period of time. So in terms of treatment, 4 persons have been, in other words, they were sick enough to require treatment. Which definitely means that for the hundreds of people that we've actually tested, only 4 of them required in-hospital treatment. And that's a very, very small number. So I hope that will be able to help me. I think so far, we could probably say about 500 persons were tested. And of course, we will really, really get a better number as we continue this conversation. And this is consistent with what we've been seeing worldwide, that, as we have said, the number of people with the disease, majority of them are not going to be sick enough to require hospitalization. As you can see, we have 14 confirmed cases, and about 4 of them were sick enough to actually require hospital treatment. I must say, though, for the 4 that required hospital treatment, we are very thankful to the Lord that the treatment that they require would not treatment for severe disease. After looking at what has transpired, it was still mild disease, but I suppose a certain level of fear and anxiety from the persons early up required them to come in. So at the end of the day, again, the treatment that they received was not for severeness, very severe illness, but it was still on quote unquote mild enough that required just 1 or 2 days hospitalization or a few days hospitalization and then discharge.
Doc, I wanted to ask, I'm not sure if you would have that information, but I'm going to ask anyway. I am concerned about the cases in Dominican Republic. They are the hardest hit country in the region. Up to this morning, there were 5,000 plus confirmed cases. Do you by chance have an idea of what might be going wrong in Dominican Republic that they have been so hard hit with the virus?
As we can see from around the world, it seems as though health systems that are weakest are the ones that suffer most. And the Director General of WHO, since the infection was in Wuhan, he continued to say to people that this infection, and the reason why it was declared a public health emergency of international importance, was not because of what was happening in China, but was what was going to happen outside of China, especially in developing countries. That is what he said. And that is what we see developing, that for health systems that are weak, especially health systems that are weak, that have lots of disenfranchised people or vulnerable people, if you want to put it that way, the poor, communities with poor health access, communities that are overburdened and overwhelmed in terms of their numbers. So I think part of what is playing out in the Dominican Republic and other places, if you really look at where the infection is hardest hit, it is in areas that have poor health systems, poor access to health care, people on the lower socioeconomic status. There are probably some racial and gender disparities as well. And so this is one of the reasons why you may see this happening. I may also say that places like Guadeloupe and Martinique, because they have very direct communications with France, for example, this is why we've seen that level of infections there as well. So it is, when you put that in context, it puts us in a position to say that we're happy with what the decisions we made very early up in order to keep ourselves at this relatively stable position as we speak now.
All right, let's go back to the phone lines. Good morning.
Morning, greetings, Blossom. And greetings to the doctor. My question to the doctor, and also my concern, is that, is it the one world order in place or the one world government in place, or our ancestors putting back things in the right place? Give thanks. That's my question.
Thank you, caller.
Well, I don't know about the one world order, but I would say, as one of my good friend sociologists have said, this corona is putting the world to rest. It's giving the world a little rest.
I agree. That's what I said.
I literally think so. It's putting the world a little rest. And for a previous caller, we have done in excess of 600 tests so far. And we're going to be able to test about 1% of our population by the end of this week. Our target is that by the end of this week. So I think this is really good going for hardworking public health professionals and district medical officers out there.
And that's including both PCR and rapid testing?
Yes, combination of PCR and rapid testing.
Okay. There's a question on Facebook. Can a faulty test kit give the type of results you have been given, or is it a malfunction with the testing machine with the results you got in the past that was negative? Would you test them all over again based on the last results you are now dealing with at present?
That individual is absolutely correct. There is, in any case where there is a process going on and human has to be involved, there is two things: human error. Even if you've done the best you can, sometimes there's human error. And secondly, error on the part of the kit itself. And hence the reason that even if you get a negative result, if that case really looks like a dog and quacks like a duck, not dog, quacks like a duck, looks like a duck, although you get a negative result, please repeat. We have had situations in the practice of medicine, even before COVID came, where as a doctor, you have a certain diagnosis in your head. You send to the lab, you get the result, it doesn't look what you have in your head. Many doctors, what they're gonna do, they will repeat the test. And so that is exactly what was done with this individual. It's like a glucose finger stick. We do glucose finger stick to tell if people's blood sugar is high, but that glucose finger stick is a screening test. It does not confirm that you have diabetes. It says that your blood sugar is high. What we now do, send to the lab for the confirmation test to prove that you have diabetes. And so these types of point of care testing, meaning care testing that you do at the point when you see the patients, these point of care testings always comes with that level of concern that the healthcare provider must always keep at the tip of his finger to be able to diagnose if he has a strong suspicion that the case is indeed that case.
Testing in Carriacou. We have done testing in Carriacou. Yes, there's a question that asks when testing on the Sister Isles will get underway.
Oh, testing in the sister eyes have already gotten underway. And if we were not using this technology, I was going to give you the latest statistics from our public health nurse in Carriacou. I'm trying to remember. I looked at it last night, and I think she has about 20-something or 26 or so rapid tests that have been conducted in Carriacou so far. And by the way, Carriacou has a good supply of rapid tests and swabs in the event that they need to swab someone for PCR or rapid tests. So by the end of the day today, we get an even higher number of tests done in Carriacou.
Does the rapid test also include the very long, what I call cotton swab up the nose? To the back of the brain?
That one that's a sample collection swab, and that one is for PCR.
Okay, so rapid test. Okay, so I'll do the rapid test. Just checking this.
No, but if you have a strong suspicion, we're swabbing you.
No suspicion. Let's go back to the phone lines. Okay,
right.
We lost that person. The phone is ringing again. Let's go back to the phone lines. Good morning.
Good morning. I'm concerned about a case concerning the Grenadians or nationalities of Grenada. That the tourism, at least the tourism minister said that they will have to come back on these
on the cruise ships.
You're right. I don't think the safest place for they put these people is at the home when they come, because to a quarantine, because we don't know what's going on, and we really, really want nothing to come back in this place here, We little bit we have here, we thank God, but we can't really take chances to let people just come and bring it in, I don't know what so much is the reason that they're so talking about getting rice and gravy. At least wherever you are, and if you have a problem and a crisis, you have to abide and be content still until, the case come to the betterment that you could make your shift. But making shift in this time just because of a little rice and gravy, at least we all have to come to cope with contentment in times of these sacrificial times. So I don't hope that they come and they really spread nothing here further than it should. I hope they put them in a place of quarantine that is real safe and not these home. I don't think the home might be safe. So I thank you.
Thank you, caller. Doc?
All right. Well, I do have very good news for this caller in the sense that we already have identified a location. We have identified the surveillance team. We have identified our security team to manage and house all these returning nationals whenever this decision is made to have them come home.
Let me go back to the phone lines. Good morning.
Good morning, Blossom. I was just going to suggest something to you, but then I just heard it that you all have found the place. My suggestion is that place of Bacolet, where they have the little boys in them. Send the bigger one who commit good crime in prison and send the rest of the good ones back home. And that's a good place to put these people who's coming back from the boat. Or send them to Tufton Hall or somewhere or the other. What do you think about that? So let me hear what you say.
Thank you, caller.
Because of the numbers of persons we were expecting, I think that facility would be inadequate. As a matter of fact, I call my COVID coordinator this morning and I tell him we have started our work in the event that this turns out to be a case, and we have to be prepared in case it is. We need space. So he started nodding his head. I hope he's listening to this program as well, because we probably might need a lot more space. But that place at Grand Bacolet probably would be too small for something like that.
I see we are joined by Dr. Charles, epidemiologist in the ministry. Doc, good morning, and thank you for joining us this morning. Doc, can you hear me?
I don't think he has to unmute his mic.
Unmute him, right.
Hi, good morning. Yes, I can hear you loud and clear.
Good morning, and thank you again for joining us. I'm not sure if you may be able to shed some light or help. We've asked about the number of tests that have been carried out. Dr. Martin just said 600. But if you can specify maybe, the rapid tests that we've done, PCR tests that we've done so far in our COVID-19 fight. Can you clarify those figures for us?
All right. So with regards to PCR, we have done about I believe it's 134 in total. Just 1 second. Sorry, 139 PCR tests. In terms of rapid tests, I don't have the numbers because at present we have ongoing testing, so the numbers are going to be preliminary. I'm sure Dr. Martin might have looked at the numbers that was sent in.
It's consistent with what I was thinking earlier, which is about 600 minus 139. Right. Initially, I said the excess of 400 rapid tests. So it's about 461 rapid tests so far, and then 139 PCR.
When it comes to the rapid tests, how do you decide who should be tested rapidly? Is that people volunteer or through contact tracing alone that you do rapid tests, or you have to be exhibiting symptoms? How do you decide who gets the rapid test? The PCR I would understand, but in terms of the rapid testing, how do you decide who gets tested rapidly?
Well, the thing is, my suggestion to the team, just as we do in medicine, is always a case-by-case basis. You cannot treat everyone with the same paintbrush. So with every contact that is identified, a simple history will be taken. And from that history, a decision will be made whether or not we should test someone for the virus itself or for the antibodies, which is this is what the rapid test. So if on doing a history of that person, the clinician determined that that person is probably shedding virus at the moment, or that person probably has a viral load on them at the moment, a PCR will be done. But if the clinician feels that that person is not shedding virus, that person may have been exposed to the COVID a few weeks ago or a few months ago, that person was exposed to COVID, but that person does not have any symptoms at all whatsoever, and the other circumstances surrounding that case means that it is safe enough to do a rapid, then the clinician will make a decision to do a rapid at the moment. So it's a case-by-case basis.
Let's go back to the... Okay, we lost that caller as well. There are a few people, I'll pass it on before I forget again. There are a few people who want me to express their thanks to Dr. Martin and the team at the tree for all that they are doing. I have approximately 4 on the WhatsApp. There are 2, I believe, on the Facebook, and we've had a few over the past few weeks of people expressing their thanks. So I said, let me just pass it on to Dr. Martin, Dr. Charles, and the rest of the team.
Thank you.
Thank you.
There is a question on the Facebook. Why have we only tested so little? What became of the 300 that was initially identified?
I don't think we've tested so little, except I would ask that if that person can give us a little idea as to what do they quantify as little. Because based on our contact tracing, based on our due diligence or surveillance, I am satisfied that we have tested as many, and because we are still continuing to test, I have faith in my officers, I have faith in the process, and I believe we're doing as good as we. As a matter of fact, I think we're probably testing more than we initially ended up, sort of to do at the beginning when COVID just started. So maybe if that person can give us a little better context as to what they're, where they're coming from, then I'll be able to help them answer that question much better.
There's a question on the Facebook asking any updates on the supplies that were held up in Chile waiting to be shipped to Grenada.
In Chile?
In Chile, as was said by Senator Cox.
Oh, well, we may have to ask Senator Dr. Charles, you know anything?
No, I don't have any information
on this.
Yeah, I don't have information on that as well, so I'm not able to further explain. Somebody's asking about counseling for prospective cases before testing and after in terms of their anxiety levels. Any plans for that?
That has been a very big discussion, certainly at the NADMA level and the psychosocial support that we enlist NADMA to assist us with. It brings me back to the HIV era when that was a big deal. You needed to get pre and post HIV counseling. With the COVID situation, the speed at which it descended upon us, caused us to start thinking of psychosocial support after. But I'm glad that at least now at the NADMA level, there is the psychosocial support that is available to people, certainly through the Ministry of Social Development. And we've spoken about this day in and day out at the NADMA level. As far as the pre-counseling is concerned for anxiety, thankfully, we're not seeing a lot of persons anxious to the point where they actually need counseling. As a matter of fact, we have more people requesting testing. In other words, they want to be tested and they're interested in knowing what the status is. But the very few who may need that kind of counseling, or healthcare providers at the front line are well equipped to give them the kind of pre-counseling testing that is needed. But like I say, thankfully, it is not a huge demand now because of the people's willingness to be tested. What we find more is the need is more for post-test counseling and post-quarantine counseling and post-isolation counseling.
All right, let's go back to the phone lines. Good morning.
Yes, good morning. So I have a question for the experts on the panel. There is a lot of concern that has been verified with respect to the quality of testing kits that the Chinese government is providing not only to Grenada, but to the rest of the world. As a matter of fact, a number of OECD countries in Europe, so that we're not being sort of going down a rabbit hole with respect to getting a false sense of hope with respect to the actual numbers. Because if we're getting false negatives, false positives, then that can affect how you perform your work. And that's my question.
Thank you, caller.
All right, well, I'll say this in two ways. First of all, I've answered that question already regarding the use of those tests. And so we will be guided by the World Health Organization whenever their report is out. So I've answered that already. But in this particular instance, I'm just going to give our own experience here. Prior to starting to use this rapid test that we have here, we did an internal evaluation, a validation, in the sense that we took known cases, known results, and used the kits to test the known results, both negatives and positive. And in all of the cases where we use this test kit to test our known result, in all of the cases, we got the answer that we were expecting. So because of that internal local validation, we felt that it was safe enough to at least use it for screening purposes. And I need to confirm that this is for screening purposes, is not for confirmation, because the only test that can be used for confirmation is a PCR.
There have been concerns about the possible hold on, I'm thinking about how to phrase it. The possible spread of the virus through patient 15 because he has been to the general hospital. There were concerns that he went to casualty and then he was put onto the male medical ward before he was taken to isolation. Are we concerned about that interaction with public space as it relates to, even though he is not really confirmed positive as yet?
Absolutely. And as healthcare providers, this is where the rubber really hits the road. So I am with that caller. As chief medical officer, that keeps me awake, working with the medical director at the hospital to identify the risks. What I can say so far is the medical director has put together a plan as to how to screen, first of all, quarantine exposed staff, and a plan of how to screen and when to screen, because as we said before, it takes a while for symptoms to develop, or it takes a while for antibodies to be formed. She has put that in place, and so there are healthcare providers on quarantine and healthcare providers to be screened. She has also screened those who met the criteria for screening already, meaning that they were in contact with this patient some days ago. As of yesterday, the screening for healthcare staff were all negative as of yesterday. So to the caller, yes, you're right. We're following that scenario step by step, and we're trying to do the best that we can to ensure that we have a good outcome from this situation.
Right. If I might be allowed to add, it must be remembered that our healthcare providers were all trained and instructed to use standard precaution always, right? So they were wearing the protection, that is the masks and gloves, and observing the protocol that the hospital has established to reduce the transmission of disease, right? So within the healthcare environment, we are confident that, once we continue to follow all these protocols and guidelines that we have set out, we would limit the transmission of disease within that environment.
There is a concern from somebody on the WhatsApp as it relates to the spread of the virus to and through animals. I've only seen just a few cases. The tiger in this zoo. There was a dog in China, I believe it was. Is it a major concern for health officials, whether here locally or around the world?
I don't know if the epidemiologist has had any research, because he seems to be checking the literature almost on a daily basis. But so far, I have not come up with any studies or research in that. Dr. Charles, have you?
Well, what I can say is it has been shown that is not significant or an important means of transmission with regards to this outbreak. We have seen the disease or the virus being detected in animals, but we have no evidence that these animals have gone on to spread disease to humans.
There's an inquiry on Facebook. The tests done locally, do they have to be verified by CAFA?
The test locally does not always or necessarily need to be verified by CAFA in every sense, in every single case. The labs in our region has a protocol that they go through and a process that they go through called validation. And once they follow that, and they have been following it up, then we trust them. But it is not absolutely necessary that every single test at every single day is sent to CAFA for verification or validation.
If I might add, the last positives that we received, they were all validated by retesting at CAFA.
Absolutely, yeah.
Okay.
And which speaks good to for our labs facility here.
We're doing good things. Let's go back to the phone lines. Good morning.
Good morning, my sister. Good morning to you, brother. Dr. Martin. How are you? Dr. Martin, the last press conference you were in, I feel you release. I see the release on you. Like you was carrying the whole of Grenada on your back. But this morning I find you pick up a little bit of the weight again. I just want to ask, you all frontline doctors, you all have any decision in opening the gateway? Like we had 2 days, now they extended to 3. I just want to know if all you the frontline doctors have anything to do with it, because I want, when anything happens, I just want to know all you had decision making in opening it too. And I want all of you to know, the frontline doctors, the nurses, the cleaners and everybody are praying for you all, because it's not an easy case. Have a good morning.
Thank you, caller. Doc?
Well, I thank that caller for the vote of confidence. I'm sorry that my face always shows the burden of the health of Grenada. But I understand the implications of the office that I hold, and I take it very seriously. So sometimes people might be able to see when I'm happy and when I'm sad. I have no problems with showing my emotions in that respect, because I am only human. But what I can say to the nation is that the committee and the subcommittee of the COVID, they respect the opinion of Dr. Charles and myself. Every single day, sometimes more than once a day, we're called upon for opinion and discussion on matters related to the response and how the country flows. I am satisfied that we are given enough respect. I am satisfied that Dr. Charles's opinion and mine have always been taken into consideration when the final decisions are made. And as of this point, I am happy with the decisions.
I think that I've already robbed some of Joseph's time. So I think it's time we wrap up. Doc, going forward, as we continue our fight, we wait on results from patient 15. What's the next step? I guess maybe we can start with Dr. Charles as it relates to testing and going forward from today, the 22nd. What's on the plans for today and the near future for testing specifically?
Well, the plans are for continued search. I mean, this is literally detective work. All right, and all we are doing, we are asking the public to assist us, because what we do, we trace, we question, we investigate, we follow up. And with every lead, we move on to another source. With every new, and every time we get a positive, as Minister said the other day, it's a reset and we start over and we start the entire process over. It is a lot of tedious work. If the public cooperates, follows the advice to not congregate and to not engage in activities that favor the spread of this disease, we can get past this event quickly. The disease moves from person to person. It requires a person to contact another person to spread. If persons listen, we can get past this quickly. All right? So we just ask for everyone's cooperation, and we will continue to do the work. All right, we will continue to lose sleep and to try and look after the interests of everyone else. But we really need everyone's cooperation. Even as the government tries to assist in allowing people to have some comfort in their lives, we really wish that everyone would at least adhere to the health measures that are being recommended, so that they can assist us all in getting past COVID in a more expedient, in a quicker time.
Dr. Martin?
And for me, just to tell the nation that again, we've been changing gears since the beginning of this, and so we're in gear number 5, and that is TTT: test, track, and treat. We got to get people tested. We got to track what they're doing and treat the circumstances that we find out. So this is where the investigations that Dr. Charles has said, the investigation is going to be gone into high gear as we try to test as much as we can, track those we need to track, and treat those. In addition, I would like to say to the nation, I have been seeing and hearing of everybody asking for additional days. Everybody wants a reason to come out. Everybody wants a reason to have a day for this and a day for that. Listen, guys, if everybody gets a day, we're going to go right back to square one and everybody going to be out in the street. Let us stop asking for days. Let us go back. And the reason they ask for days is people don't want to make the sacrifices that they need to stay at home. This is an opportunity for your backyard gardening, so you don't need, yes, I know we need the farmers, but it's an opportunity for you to bunker down and find ways to function within yourself. Stop asking for more days. We're going to do the best we can to give access as we can, but the health of the nation must be our first priority, and the decision, we have to take that as our first priority. The last but not least is to thank the Almighty God for where we have been thus far. I know we've done a lot of work. I know that a lot of work has gone into the science of it. In fact, on a daily basis, when the committee speaks to us, they refer to us as the scientists. Dr. Charles and I never thought we were scientists in that regard, but they do listen to what we have to say. But as a religious nation, I know the religious community out there has been praying a lot for us. In fact, I've gotten calls from clergy members and other persons who personally said that they're petitioning God on our behalf. And so we really like to thank the Lord for helping us to reach thus far. And because he has done this thus far, there's a song that says, he'll never bring us this far to leave us. He'll never lift us up to let us down. he would not build a home in us to move away. He's always there to be there for us. So I have faith and hope in this as this country continues to pray and stay on our behalf. We are going to get through this together. Thank you.
Speaking of treatment, what are we treating the patients with? Are we still looking into chloroquine? Chloroquine and the one from Cuba.
Treatment here means you treat whatever circumstance you have. Let me give you 3 examples. Either is a home with 1 person positive and the 2 persons negative, then the treatment here is removing the positive from that situation. And you put them in a place so that they can stay by themselves. So treatment here doesn't always mean medication. It means dealing with the circumstances that you have at the moment. But if you're sick, you're unwell, then treatment here would mean getting into hospital so that you can be put on the azithromycin and hydrochloroquine and the oxygen, of course, as necessary.
Just checking. Thank you very much, Dr. Charles and Dr. Martin, for sparing us some of your busy COVID-19 time. We appreciate it, as always. Thank you very much. Have yourselves a good day. Stay safe and COVID-free.
Thank you.
All right. I want to thank the Acting Chief Medical Officer, Dr. Francis Martin, and Epidemiologist, Dr. Shawn Charles, for being our guests this morning on To The Point. Appreciate it as always. That's the end of my time today. Thank you guys so much for tuning in. Those of you that posed your questions, those of you that are still WhatsApping your questions, thank you guys once again. Stick and stay right here. Joseph is up next with Mid-Morning Buzz. He's watching me cross-eye from across the room because he's ready to get the day started. He will take you through to midday. Have yourselves a very blessed, wonderful Wednesday. Until next time, stay COVID-19 free. Sorry, Joseph is trying to spray me with spirits. Until then, have yourselves a good day, everybody.